Welcome to our video on trauma and stressor disorders. Trauma disorders are multifaceted, often leading to conditions like PTSD, CPTSD, or BPD. These disorders share overlapping symptoms, making accurate diagnosis challenging. Misdiagnosis can result in stigma and ineffective treatment, emphasizing the need for clarity.
Post-traumatic stress disorder, PTSD, is a psychiatric condition that develops after exposure to a traumatic event involving actual or threatened death, serious injury, or sexual violence. Individuals with PTSD often experience intrusive memories, flashbacks, avoidance of trauma reminders, negative changes in mood and cognition, and heightened arousals such as hypervigilance and sleep disturbances, APA 2022. Complex PTSD, CPTSD, as defined in the ICD-11, includes the core symptoms of PTSD, but is distinguished by additional features collectively referred to as disturbances in self-organization, DSO. These include persistent affect dysregulation, negative self-concept, and difficulties in interpersonal relationships, typically arising from chronic or repeated trauma, especially during early development, Cloitre et al., 2019, WHO, 2024. In contrast, borderline personality disorder, BPD, is a personality disorder marked by pervasive patterns of emotional instability, intense and unstable relationships, chronic feelings of emptiness, impulsivity, identity disturbance, and recurrent suicidal or self-harming behaviors, APA 2022. These disorders share several overlapping features, including emotional dysregulation, interpersonal dysfunction, dissociation, and identity disturbance, particularly in trauma-exposed women. Frost et al. 2020, Claries et al. 2024. However, they differ significantly in etiology, structure, and treatment implications. PTSD and CPTSD are trauma-related disorders, with symptoms linked directly to traumatic exposure, while BPD is considered a personality disorder with enduring traits that manifest across contexts. CPTSD differs from BPD in that its emotional dysregulation and interpersonal difficulties are typically trauma-derived and more stable, whereas BPD presents with more reactive and impulsive symptom patterns. Accurate differential diagnosis is crucial, as misidentification, such as diagnosing BPD in women with unrecognized CPTSD, can lead to stigma and ineffective treatment. Lonin and Pascal, 2024.
Understanding these disorders is crucial for improving outcomes. By distinguishing between PTSD, CPTSD, and BPD, we can tailor treatments effectively. This video will explore these complexities, offering insights into accurate diagnosis and better therapeutic approaches.
The DSM-5-TR and ICD-11 frameworks provide guidelines for diagnosing PTSD, CPTSD, and BPD. Each has its strengths and limitations, influencing how clinicians interpret symptoms and make diagnoses.
Tools like CAPS-5, PCL-5-ITQ, and MSI-BPD are pivotal in diagnosis. However, their effectiveness varies. Using the right tool is essential for accurate diagnosis, ensuring patients receive appropriate care. PTSD is more prevalent in women, yet BPD is often overdiagnosed. Gender biases can distort diagnosis, leading to misinterpretation of trauma symptoms as personality disorders.
Understanding gender dynamics is crucial for accurate diagnosis. By recognizing these biases, clinicians can avoid misdiagnosis and provide more effective, personalized treatment plans.
Advocating for trauma-informed, gender-sensitive diagnostic practices is essential. Emphasizing dimensional models that reflect trauma's continuum can lead to more accurate diagnoses and better patient outcomes.
Encourage the use of tools that capture disturbances in self-organization. By adopting these practices, we can improve diagnostic accuracy and enhance therapeutic interventions for trauma-affected individuals. Thank you for watching.